So please welcome our dynamo, Shari Kogan.
So I knew I had this somewhere, and I brought this newspaper article. It's been driving around in the trunk of my car along with all kinds of other crazy things. And basically justifying our talk today that overdoses, deadlier than car crashes, as the -- cause of injury in the state of Hawaii. The -- cause of death from injury, not from diseases, from injuries. So in terms of injurious deaths, the #1 death in the state of Hawaii is too many drugs. Done with my talk? I can go. Okay, so more than car crashes, more than falls, which is totally amazing to me, more than drowning, more than shark attack, more than coconuts falling on people's heads and knocking them out, more than suffocation. Overdoses. Overdoses of what were they talking about? Meth and pot and stuff that you don't do? Heck no, boys and girls. Overdoses of prescription drugs. All right, I've got your attention. Okay, so, And the side effects, sure, we'll talk about the side effects. What doesn't kill you actually doesn't necessarily make you stronger. What doesn't kill me makes me sicker. That won't be a really good song. Okay, so let's see, what are we gonna do? Today, by the end of today, you'll be able to talk about the pharmacokinetic changes of aging, which is such a cool thing to say to your, nephews and nieces and kids, let's discuss pharmacokinetics. You'll be able to talk about potentially inappropriate medications for people who are getting older. And I'm gonna give you a tool box. You'll have a bunch of tools that you can take home, and you could, not that kind of tool, but that you could use to kind of look at different medication lists and see hey, maybe there's a concern here, okay? First of all, I also wanna say, wow, congratulations, and kudos to all you people for coming out on a Saturday morning and sitting through long talks about how you're gonna die from heart disease and how you're gonna die from too many drugs. And oh my God, Virginia, seriously, woman. Okay, so we'll talk about, I'll just make a case for the evidence of the epidemic. I think check, right? And why, I guess we'll move on to the next thing, physiological changes that underlie the problem. Actually, here's just some statistics about why this is such an epidemic in the United States, or why it's a concern in the United States. This is basically a first world problem. When you go to the third world, this doesn't tend to be as much of an issue. So this is a disease of wealth, is what it turns out to be. Or what I like to call white people problems. This is not a disease, for African nations. This is something that we, much like heart disease, this is a disease in many ways of wealth. Because most people in third world nations don't live long enough to die of heart disease. And most other nations, you don't have enough money to die of prescription drug overdose. So you should feel very lucky indeed. Yeah. Okay, so basically I'll just go to the last one. So as we get older, we tend to accumulate more drugs in the United States. And as we get, the oldest old of us is taking the most drugs. That women are taking more than 10 prescriptions daily is just, okay. This is one of my favorite cartoons. She's one of my favorite cartoonists. It's really kind of blurry as you see it up here, but it's the Pill of the Month Club. And so you see January is Prozac for those winter doldrums, and February's Pill of the Month is Viagra for Valentine vigor. Okay. Okay, I want to make sure that this is, okay, so take-home message number 1 is that we're all so lucky to be dying of prescription overdoses. No, that wasn't it. What was it? Oh, okay, that we take too many drugs. Take home lesson number 2. If you decide after this you're going to take a nap and you're not going to listen to the rest of my lecture, that's fine. Just remember that I consider this a drug, even though it's non-prescription. So when you go home and you look at your list of drugs with the tools I give you, remember that that is a drug. Self-prescribed. Especially in Hawaii, we're using a lot. Even the older people are still doing a lot of current, binge, and heavy alcohol use. And driving under the influence. Thank you very much. And older people, just because I said we're going to talk about prescription drugs, doesn't mean that older people are not using illicit drugs, illegal drugs. As a matter of fact, I work at Queens Medical Center. I work with Dr. Hong, sometimes against Dr. Hong, depending on what the issue is. And I'm seeing, to me, a shocking number of older people who are coming in who are using heroin and meth and illegal drugs, which, we used to thought was just the purview of, young people. But we're also taking drugs that don't have an indication, and this is in partnership with your physician, I have to say, that in the United States right now, the reason in my mind that this is an epidemic is that we've developed a very dysfunctional relationship with our physicians, and that we go to the doctor and we have something that's bothering us. And I'm an internist, I'm not a surgeon. If you go to the surgeon and you have a complaint, they will try to cut something out of you. Because that's what they know. There's an expression, when the only tool you have is a hammer, every problem looks like a nail. So when I'm an internist, what do? We're not allowed to cut things out in general. So we have a prescription pad. That is our tool, right? We can also educate people and talk to them, but that takes time and you're not interested in listening, blah, blah, blah. It's all going to be about lifestyle change. No one's going to change their lifestyle. We're Americans. We want a pill for it. We pay taxes, very high taxes. There's got to be a pill that fixes this. And doctors have bought into that, and society has bought into that, so that when you go to your doctor, if you could change it by changing your lifestyle, you would have done it before that. You would have looked it up on Dr. Google, and you would have exercised more, you would have quit smoking, whatever. But now you're short of breath, you go to your doctor, you want a pill. And if your doctor doesn't give you a pill, what do you think? Time for a new doctor. He doesn't care. He's not listening, right? And doctors have been trained over time that we know that if we don't give you a pill, you're thinking, that doctor doesn't care. He's not listening. My feet hurt. He's not listening. My stools are loose. He's not listening. That rash is really itchy. He's not listening. So what does the doctor feel like? After all these years, you have trained your doctor that if you complain about something, your doctor's going to give you a pill. Even if there's no indication. So older people will, indication, that means like a drug was designed for a certain purpose, and the doctor gives it to you for that purpose. So I work in the hospital, I'm a consultant, so I see everybody else's mistakes, which is a much better place to be than people seeing my mistakes. And sometimes I have, and so I see people that come in with this long laundry list of drugs that then they fall in the community. This is pretty much my typical day. They get admitted to the hospital. I get consulted by the trauma service, because falls are traumatic injuries, so they get admitted to a trauma service, which is surgeons. And they say, oh, Dr. Kogan, this person fell down. Can you tell us why? I'm like, look at this list. Look at this list. How can anybody be vertical at all on this list? And then you go through the list, and I'm like, why are you on this? Do you have an ulcer? Why are you on this? Do you have a blood clot? Why are you on this? And I can tell you that half these medicines I'm looking at, I can't even figure out why these people are on it. Maybe they had something last year. Maybe they got admitted to the hospital. They complained of a little, stomach upset from all the drugs they were on. Somebody gave them Protonics or Nexium or, pantoprazole, some kind of acid blocker for the stomach. Years later, they're still on it. They don't have an ulcer. So this is huge. Taking drugs, I can't tell you how many times I see patients who come into the hospital who are on those like bladder spasm blockers. Like you go to the doctor, you say, sometimes I leak. My shishi leaks and it's really embarrassing. And so the doctor puts them on a pill, right? I'm not gonna make you show me your hands, but I know who you are. And because it's all of you. And then, I see them later in the hospital and they're on that pill and they're wearing a pad. I'm like, help me with this. You're paying $120 a month for this pill and you're still wearing the pad. Yeah, the pill doesn't really work. Doesn't work, Why are we still on it? Why are we still on it? Taking medicines that are not even working for something that's not even a disease. It's just a symptom. It's just an annoyance. And those people fall down. Or people who are on two things, the same thing often. I'm on pantoprazole and I'm on Protonics. Hey, newsflash, you're on the same thing. You're paying twice. It doesn't work twice as much. It doesn't then make your stomach like the acid is so blocked that fairies fly out of your butt. It's you're wasting your money. Okay, so why do I care about this? It makes your life more expensive. What do I care? Really, unless you're willing to adopt me, fine, and then I care. But because the more drugs you take, the more chances are you're going to have an adverse drug reaction, right? Because every drug has the effects that we hopefully want it to achieve and a whole bevy of other effects. Sometimes the other effects are good, and I sometimes say, I'm going to use this high blood pressure medicine in you because you have trouble sleeping at night. I'm going to give it to you at night. It makes you sleepy. It's also going to be your sleeping pill. Twofer, right? Great. But sometimes it has effects that I don't want. Like maybe there's a blood pressure medicine that makes you sleepy and somebody gives it to you in the morning. And then all day long, your wife is yelling at you saying, wake up, wake up. And you say, I'm watching TV. And she says, no, you're not. Your eyes are closed. Or you say, I'm driving. Yeah. No, you're not. You're asleep. So many drug side effects are out there that we see that possibly as many of, and probably more than 12% of all hospital admissions are for a side effect of a drug that you're given that was supposed to be helping you. And the more drugs that you take, the higher your chances are of having not just a side effect because you take that many more drugs, but because these drugs work against each other in your system. And that's what we're going to talk about today. That's basically the essence of pharmacokinetics, like why drugs affect each other in your system. And this is where it's going to get pretty intense. The chemical engineers in the audience, they'll be fine with it. But, the people who were the poets and the writers, just try to stay with me. Anyway, there was once a lovely little study, and I talk about this study because I thought it was really quite beautiful. And it graphed out what percent of people had side effects from drugs, adverse side effects, not even good side effects. And they plotted it out versus how many drugs older people were taking. And they basically showed that the curve went up, logarithmically. Okay, so that's for the math teachers. So it didn't just stay straight, but that by the time you got more than 6 drugs, 100% of people in their study group had adverse drug reactions. So if you were on 6 or more drugs when you were in this study, you had adverse drug reactions. And the interesting thing that I loved about this little study is that they only looked at one adverse reaction, one specific reaction. And that reaction was, global cognitive impairment, meaning that people in their study who were on 6 or more medications became confused, cognitively impaired in a global way, goofy, delirious, encephalopathic, badness, okay? And that was just with number of drugs. They didn't break it down by what kind of drugs. They didn't look at anything, just the sheer number of drugs. And we know that from lots and lots of studies. So we know that the more drugs you take, the more likely you are to fall down, be confused, be incontinent of urine, be more dependent on others, and have increased mortality, die. Okay. I was sitting there in Dr. Hong's lecture, and he was like, blah, blah, and he's throwing out all these, like, what I call TLAs, you know, 3-letter abbreviations, and all these, like, acronyms, and I was thinking, is everybody else staying with him? So I don't know if I'm, okay, hopefully you're staying with me. So here's just cardiovascular drugs that cause, this is just heart drugs. This is not even the drugs you take for anything else, and the kind of problems that we can see from heart drugs. Confusion, vertigo, depression, falls, drop in blood pressure, unable to peeing too much. I know, welcome to life. Anyway, so we'll go through, I'm gonna give you a bunch of tools that you can use. Basically, I love this cartoon, it's basically like, the bad news is, you know, well, the good news is as you get older, you probably are wiser and smarter, but you kind of lose your, he's going to take away the tone in her upper arms, the girlish timbre of her voice, her amazing tolerance for caffeine, and her ability to digest French fries. The rest of you can stay. Okay, we're going to talk about pharmacokinetics now, so fasten your seatbelts and stay with me. Every time, here's we're getting down to the real med school thing. Somebody said to me, I said, oh, I got to give mini med school. And they said, oh, so you're going to kind of fluff it up a bit, you know? And I'm like, no, you're going to have to stay with me. Helen, I got my eyes on you. Okay, anytime you put a drug into your system, be it a drug that you got prescribed by your physician, be it a drug that you bought over the counter at, you know, CVS pharmacy, be it a drug that you self-prescribe to help you fall asleep at night, it has to get into your system and it has to get out of your system. Otherwise, that drug that you took when you were 12 years old for strep throat would still be in your system. It doesn't work like that. Everything we take in, every chemical, we have to absorb it. We have to deal with it in some way. We usually have to manipulate. Your body is this one big chemistry experiment. It will manipulate that chemical in ways so that then your body can release it. So first we have to absorb it, because you think that the minute you put something in your mouth and you swallow it, you've absorbed it. That's not absorption. It's still sitting essentially in the outside of your body, because your gut, your mouth, esophagus, stomach, small intestine, large intestine, rectum is essentially in many ways the outside of your body. That's why, like, if you swallow a nickel when you're like 4, you know, which we all did, eventually, right, you don't absorb that into your body, right? You're not then worth like a nickel more. It eventually makes its way out because it was never part of, you know, it never got absorbed into your bloodstream. It never got, you know, metabolized by your liver. So things that go into your body eventually have to get absorbed, for the most part, into your bloodstream. So drugs can go in many ways. Most of the time we think about how do drugs get into your body, you what? You swallow them, you take them orally. But take a second, there's other ways drugs get into your body. How do you have other ways? Huh? You can breathe them in. Who uses an inhaler, right? You can get it in that way, and it goes to your lungs, which are very vascular. They have a lot of blood vessels, and it gets absorbed through into your bloodstream that way. Anything else? Skin patches through the skin. It gets absorbed through the skin. There's blood vessels in there. Eventually, sometimes things are absorbed totally systemically throughout your whole system. Other times they stay more focal. Nasal. Dave does cocaine. So he knows that, like, you know, you can snort something in your nose. Thank you, Dave. That was very helpful. So absorption as we get older can be really, really tricky. There's not one general trend for it because there's so many ways things can get into your body. Even rectally, people always, like get kind of a little bit shocked when I say this, but the rectum's like one of the best ways to get drugs into the body. When I have patients who can't take things orally, I will sometimes just pop it up their bottom and there's a lot of blood supply and we can get it in there. One thing I will warn you about just as this is kind of one of my things that is a take home for yourself personally. A lot of people take calcium or they take antacids or things like that, and then you take it at the same time as you take your pills. So if you're taking things that are meant to neutralize stomach acid at the same time as you're taking drugs that need stomach acid in order to be absorbed, you will essentially be creating a non-dissolvable salt in your stomach of your drugs, and you will be creating very, very expensive doo-doo. So I generally tell my patients, don't be taking your calcium or your Tums or your antacids at the same time as you're taking your pills, especially like antibiotics or your heart medicine or things like that. And if your doctor's wondering, gosh, they're so resistant, their blood pressure is so tough to manage, I keep increasing that blood pressure medicine, and it's still, their blood pressure is so high, you may not be actually taking your blood pressure medicine. Remember what I said about your stomach is not really the inside of your body, right? So if you are binding your blood pressure medicine to a calcium pill in your stomach and creating a non-absorbable megamolecule, a big salt, you may just be pooping out most of your Norvasc. And that stuff is still pretty expensive. Okay, we're moving on. So the next thing that happens, you absorb these chemicals into your body. Either I stick it up your butt or Dave snorts his cocaine or whatever. And now it has to it gets absorbed into your bloodstream. Once a drug goes into your body, remember how I said your body is one big chemistry experiment. It's one big chemistry lab, right? And we know things about chemicals. We know that chemicals like to be either dissolved in fat or they like to be dissolved in water. And if you're going to pay attention to any part of the pharmacokinetic lecture, this is my favorite part. I think this is the part that makes the biggest difference in what happens to drugs as we age. And people don't talk about it, right? I mean, it's just volume of distribution. So what happens, you do this chemistry experiment all the time at home when you make salad dressing, okay? Because when you make salad dressing, what are the elements that go into salad dressing? Ethel, what's kind of something that goes into salad dressing? What goes into salad dressing? What's an ingredient? Anybody? Oil. Vinegar. Okay, oil is a fat, right? But vinegar is like a water-based chemical, right? So what happens when you put that oil and that vinegar together in the same container to make salad dressing? Do they mix together? No. Oil, they say oil and vinegar don't mix, right? But oil and water don't mix. Your body is much like salad dressing, some of us more than others. And you have fat components of your body, right? Which fat components, and you have water components of your body. So the water components of your body are the things that are kind of obvious when you think about them. Like your bloodstream tends to be like mostly water-based, and the fluid inside your cells tends to be, and around your cells tends to be water-based. Fat is obviously what? Right, your fat. But also the coating of your brain tends to be fat. The coating around your cells tends to be fat. And water tends to be your muscle. Muscle tends to be a very water-based component. Okay, the cells in muscle tend to be water-based. So when we talk about the water content of your body, a lot of it is based on how much muscle mass you still have. Okay? Muscle is primarily a water-based part of your body. And your fat is mostly fat-based part of your body. As we age, even if we still work really hard, As we age, we tend to be more fat and less muscle. So as we age, the total component of our total makeup of our body tends to be more fat and less water. Also, think about it this way, especially as you're listening to me like gagging for life, that as we age, we don't drink as much. We have these natural physiologic changes where we don't get thirsty as easily. The receptors, that thermostat for wanting water, tends to be downgraded. So I will sometimes go the entire day at work, and I'm leaving at the end of the day, and I realized I didn't drink anything all day. And I didn't even pee all day, and I'm thinking, I better get home and have something before I go into kidney failure. No, seriously. When you see a baby, what are babies always doing? Drinking. The baby's little fussy, what do? You give it a bottle, right? The baby's tired, wants to go to sleep, you give it a bottle. Baby wants to be picked up, you don't want to be bothered, you give it a bottle. Babies drink all day. And what do babies look like? Oh my God, they're like juicy and smooth and right? And they pee constantly. They just pee all day long, but it doesn't matter because they wear diapers, right? So babies are wet, old people are dry. So when you go into the emergency room, I don't know if you've had an auntie or a cousin who's going to every old person who comes into the emergency room gets 2 diagnoses. They get their like pneumonia or fall or urinary tract infection and dehydration. UTI and dehydration, pneumonia and dehydration. So as we get older, we get dry, which you have to remind yourself to drink more. But in general, we're dry. Okay, so now we're moving on. Everyone's got that concept, right? Drugs are like chemicals. Drugs are chemicals that are like salad dressing ingredients. When you have now your oil and your vinegar and you put in some herbs and spices, it doesn't distribute evenly throughout that salad dressing, right? You put in some chopped basil or whatever, it goes to either the top layer or the bottom layer, right? Until you kind of really work hard to shake it up. And that's like drugs in your body. Drugs are going to want to go to either the fat component of your body or the water component of your body. Okay, so drugs are, like any chemical, are going to be hydrophilic, water-loving, or lipophilic, fat-loving. Okay? And like I said, as we get older, we're more fat and less water, even if you weigh the same as you did when you were younger. Okay? Now, what does that mean for clearing drugs out of your system? Well, luckily, Dr. Hong talked about half-life, or T1/2, right? T1/2. Well, he said that's basically the time it takes for half of something to be gone. He was talking about the half-life of implantable cardiac devices, right? The T1/2 of a implantable ventricular assist device might be like 6 or 8 years. So by 6 or 8 years, half of those ventricular assist devices are no longer functioning. We're talking about drugs, same concept. How long does it take to get rid of half of the drug that you put into your body? Turns out that's very dependent on what compartment of your body it goes to. Volume of distribution is related to half-life. So the bigger the volume of distribution, the longer the half-life. Think about it this way. If you drop a bunch of, tennis balls into a little box, into a little room, and you have to pick them all up again, tiny little closet, you can pick them all up quickly. If I scatter the same amount of tennis balls over a big space, it's going to take me much longer to collect all my tennis balls, right? So the bigger the space, the longer it takes to get rid of it from that system. John here being the system, right? He is my chemical system. So, which component is bigger as we get older? The fat component. That's right. So, drugs that want to go to fat components, drugs that love fat, as you get older, are going to take a much longer time to clear out of your body. Now, remember what I said, your brain is coated with fat. So if you were going to design drugs that have to go to the brain, would you make them fat soluble or would you make them water soluble? Fat. You want them to penetrate into the brain. So any drug that you take that's designed to go to the brain, so things like sleeping pills, right? Because that has to put your brain to sleep. Antidepressants, antipsychotics, anti-anxiety pills, anything that's designed to go to the brain is going to be sticking around a lot longer because your volume of distribution is different as we get older. I ask this question every year. Ha, 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 ha. So does that mean you can take water-soluble drugs as much as you want? Who wants to take them? Who wants to go for it? Can you take then water-soluble drugs as much as you want? No, thank God. No, because, okay, I'm going to go back. That's not what I want to do. Because when you take a substance now, your water-soluble component of your body is much smaller. So what happens if we put any substance into a smaller volume? What happens to the concentration of it? It goes up. So fat-soluble drugs last longer, but water-soluble drugs will be much more concentrated. So either way, either the drug is going to stick around a lot longer, or drugs that are water-soluble are going to have a much bigger punch and even become toxic because your water-soluble component in your body is much smaller. In the beginning, I showed you a picture of a water-soluble drug. What was it? Alcohol. So what happens if you take the same dose of alcohol that you have been taking for the past 50 years? Huh? Thank you. Dave, thank you. Dave just said, you'll be drunk, right? And Dave knows about those things because we know how he is. But he's a cheap date. And so are you. We have all become cheap dates. And so that's why when, we get older people into the hospital, they get admitted for pneumonia or they get admitted because they're falling down, even more so. And I say, well, how much does, Auntie drink? Oh, she's not an alcoholic. She's not an alcoholic. That's the first thing everybody says. I'm like, that wasn't my question. Thanks for answering it, though. And I said, well, how much does she drink? She only has 2 glasses of wine every night, but she's always had that. She's always had that. She's always had that. Everybody's very defensive about their alcohol. I'm like, you're really not that defensive about your laxatives, so, I don't know why we're... So why did Auntie fall down? She's, and I believe you, always had 2 drinks every night, 2 glasses of wine, 1 before dinner, 1 with dinner, her whole life. Why did Auntie fall down? Because it's more concentrated. Because she thinks she's having 2 drinks, but her system thinks she's having 6 drinks. So her system thinks that she just downed a bottle and a half of cheap swill, okay? And she has become a cheap date, right? And so even though we think, I'm not drinking anymore, nothing's changed, we have changed. Your liver has changed. Your volume of distribution has changed. If you remember nothing else and you leave after this, and this is the only thing you learn, I will be completely content and you will be much better prepared for the world. But we're going to go on because other things that happen with volume of distribution are when you put a chemical into your body, when you put a drug into your body, drugs in the body like to go around bound to protein. In your bloodstream, you have little molecules, mostly albumin, but all sorts of other proteins as well, P-glycoprotein and all sorts of different proteins. The primary one being albumin. And drugs, when you take them, you absorb them into your bloodstream, and then they attach to protein, okay? As we age, what happens to albumin in our systems? Goes down. Albumin goes down. So there are fewer molecules of albumin that drugs can bind to. Okay, if that was the end of the story, that wouldn't be a big deal. However, there's more to the story. First of all, that means more and more drugs are competing for those few albumin molecules. And just like a game of musical chairs, when you pull out one of the chairs, you pull out one of the albumin molecules, somebody's going around unbound, right? Some drugs are going around not bound at all to protein. In your chemical system, in your body, the drugs that are free are the drugs that are active. Those are the ones that are really doing the work. The ones that are bound tend to be the reservoir, sort of your backup ones that are waiting to be used. So free drug tends to be active drug. So when these drugs are designed and when the dosages are designed and when they're designed with the idea in mind that some of the drug that we give you is going to be just kind of held in reserve, bound to your albumin, and only a small amount is going to be active and free. However, that was designed for somebody that had way more albumin than you and I. It was designed for somebody who had the albumin of a 20-year-old. We don't have that much albumin anymore. Okay, not only that, 20-year-olds, maybe they take one drug. Maybe they take birth control pills. Or maybe they take, marijuana. It's their one drug, right? We already know that we take 6 to 8 to 10 to 12 drugs. So all those drugs are competing for those diminishing albumin reserves. So much more of the drugs that we take are going around free and going around active. Means you're going to have not just the effects of those drugs, but the side effects of those drugs. So free drug is active drug, is drug that can cause more problems. So this is like classic I see all the time. So somebody has a little atrial fibrillation, they've got some high blood pressure, they've got whatever, and their cardiologist puts them on some blood pressure meds and puts them on digoxin for rate control so that their heart rate doesn't go too fast. And they're going along just fine with their heart rate of about 80, and they're able to play tennis, and they're able to do this. But one day they're playing tennis and they kind of hurt their knee, so they go to Mina Pharmacy or Long's or even Safeway, and they buy some ibuprofen, Motrin, over the counter, right? It's over the counter, so it's safe, right? Edna? Thank you. No, it is not safe. So they take some Motrin, and they go home, and then they take just what it says on the bottle. They take 2 Motrin, and they wake up the next morning, and they are so tired. They can't play tennis. They don't even feel like they should drive, and they're not sure what's going on, and they go to the doctor, and their heart rate is now 35. And the doctor says, Edna, you're taking too much of your digoxin. And you're like, heck no, I take it, I lay it out in the pills, and they're thinking, Edna is a liar, right? She's just been mixing everything up, and right? Edna, did you take more of your digoxin? No, you didn't. What did you take? You took 2 Motrin, didn't you? And what your cardiologist doesn't realize is that Motrin is highly bound to protein. Motrin loves protein, as do plenty of other drugs. And what happened? That Motrin then got absorbed into Edna's system, and it fought for those albumin molecules. And when that Motrin grabbed on to that albumin molecule, what did it knock off? It knocked off her digoxin. Now, all of a sudden, twice as much of her digoxin is active and is free and is active. So instead of getting her heart rate down to 80, it's now brought her heart rate down to 35, 40 because she took 2 Motrin. And that's why volume of distribution is important. Okay. Anyway, blah, 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 blah. So if you're taking other drugs that have what we call like a narrow therapeutic window, drugs like where a little bit is good, but a lot is bad. So drugs like Coumadin or warfarin, drugs like digoxin, drugs like theophylline, drugs like, oh my gosh, I could go on and on and on. You can't just go ahead and take, something over the counter. You can't just, because everything you take is competing in a closed system, right? For protein binding, we'll go on, metabolisms. Oh, and also, if your doctor says, well, I'll just check your digoxin level, it's not the dig, it has to be something else. I'll just check your dig level at the lab. That's going to be very misleading, because the lab is still going to tell you total dig levels, not how much is free. So you can't rely on just, somebody else to solve this problem for you. You have to Sherlock Holmes your way through this. You have to really puzzle it out. Okay. The next thing that happens, so now the drug is distributed all through your body. Now you have to metabolize it. The vast majority of drugs don't then just get absorbed and then released from your body in the same chemical. Most drugs must go to your liver and become a different chemical. And as we age, the ability to break that drug down into these new chemicals, break it down into smaller chemicals, becomes much, much more difficult. Our livers get smaller, they have less blood flow, and there's more competition for those pathways that remain because we're taking more drugs, right? So one of the first tools that I'm going to give you is a chart of the P450 system. Now, when your drugs go to your liver to get metabolized, as they generally do, they can get broken down by two ways. One's like glucuronidation kind of pathway where they get attached to a sugar molecule. The other way is by oxidative reduction reactions. I said that for the chemists in the room. And this pathway tends to slow down as we get older. This is the pathway that does a lot of important drugs, and it gets a lot slower. And there's competition. So now, here's the website that I like to use. And it's from the University of Indiana. And they have a really good pharmacology school there. And it's not the only one that you can use. There's lots of other P450 charts out there. But basically, your drugs, if you take more and more drugs, they're waiting in line at these enzymes to be metabolized. And you're not going to get rid of them until they get metabolized at the liver. Okay. Finally, your drugs get metabolized, and actually it's one of my favorite things to play with, and people get so impressed, like when you take the list of their drugs and you say, well, this is metabolized by CYP, 2D6, and this one's metabolized by, CYP, 3A4, 5, and 7. And what's lovely about that chart is you'll see that it also shows you which drugs that you're also taking inhibit the enzymes that were supposed to break up the drugs in the first place. So anybody who's on warfarin, I'm not going to ask for a show of hands, but if you know of somebody who's on warfarin, and there's lots and lots of people who are out there who are on that blood thinner, you must check this chart before you let anybody add anything or subtract anything from your drug list, okay? And this is the reason why we see a lot of people who maybe who are on warfarin for atrial fibrillation or an old blood clot in the leg, and then they get a urinary tract infection or pneumonia, and the doctor puts them on Cipro because that's a totally unrelated problem, right? The pneumonia. So it's not going to affect the blood clot, right? Ruth? Ruth? Ruth?
Yes.
Wrong. Neva, what's going to happen?
What's the question?
So just because it's an unrelated problem, remember this is a closed chemical system. You can't put in ciprofloxacin, an antibiotic, and think it's not going to affect the warfarin. So ciprofloxacin is going to block the enzyme that metabolizes your warfarin. And remember, you have to metabolize your warfarin to get it out. So then what's going to happen to your warfarin? It's going to go up. How are you going to know your warfarin's going up? You're going to start to bleed, right? You're going to start to bleed. You're going to call your doctor because there's blood in your stool or your nose is bleeding or, or your doctor's going to bring you in for your regular Coumadin check, right? And he's going to say, what the heck? What are you doing? It's not what you're doing. It's what he did. He put you on the Cipro, right? But remember what Dr. Hong said. You have to be part, right? You're a partner in this. Your doctor's not pooping blood. You are, right? Well, he might be. But if he's not checking, right? So you have to be part of this. You have to be an active participant. You have to say, am I allowed to add Cipro to warfarin? I mean, you can if you need to, but then someone's got to be checking those blood tests way more frequently. And maybe adjusting your warfarin dose while you're on the Coumadin. Or maybe choosing a different antibiotic. I'm not saying don't take drugs. I mean, better living through chemistry. I mean, we live longer than most other people on the planet. Yes, mostly it's because we have indoor plumbing and closed sewer systems, so we're not dying of dysentery, but some of it is because we have great drugs, and we've done great things. Cancer used to be a terminal illness. Cancer is no longer a terminal illness because we have drugs now. So now cancer has become a chronic illness. People live with their cancers. High blood pressure used to be a death sentence. Diabetes used to be a death sentence. We live with them now because you can't go to a surgeon for diabetes. They can't cut out the diabetes tumor, there are some, but you can't do that. So you live with it because of drugs, because of chemicals, and that's a good thing. Even AIDS, HIV, used to be a death sentence. Now people live with their HIV because we have drugs. Drugs are not necessarily a bad thing. But drugs are a bad thing if you think that you can just use it indiscriminately. Drugs are a tool, and you have to know what to do with the tool. It's like a hammer, right? A hammer's a tool. But if you try to fix your television set with a hammer, you're going to have a broken TV set, right? So you have to, my plea today is to use these things with finesse. Okay, now you've metabolized this drug, so you've broken down the chemicals. Now it has to be eliminated from your system, okay? So elimination happens sometimes through the gut, but mostly in the kidneys. Most drugs are eliminated through the kidneys. As we age, our kidneys are, like everything else, much less efficient. And remember we talked about that half-life equation before. T1/2 is the half-life. That's how long drugs stick around in your system. Well, the bigger the volume and distribution, the longer drugs stay around. But the number over here, the factor over here, is creatinine clearance, which is basically a reflection of kidney function. So the slower your kidneys are, the longer drugs are going to stick around. And as we age, even if the lab test says your kidneys look good, let me tell you, your kidneys aren't as good as they were. Remember what I said about lab tests. You can't just get a lab test, oh, there's the number, we're done. You have to Sherlock Holmes it a bit. You have to puzzle it out and figure out what's going on. The lab test that your doctor uses to look at your kidneys is a creatinine level. And he looks at, if your creatinine is going up, he says, ooh, your kidneys are sluggish. They're not clearing your creatinine. And if your creatinine is low, he says, ooh, you've got fabulous kidneys. Look at how low your creatinine is. That's great, right? I've got a low creatinine level. My kidneys are great. Yay! Creatinine comes from the everyday breakdown of muscle tissue. Muscle tissue. We were talking about muscle tissue earlier, weren't we? What happens to muscle tissue as we get older? It diminishes, even if you're the same weight as you were when you were younger. So creatinine comes from the everyday sort of breakdown of muscle tissue. So if your muscle tissue started out lower to begin with, should you still have a normal creatinine level? No, right? So what does a normal creatinine level mean in a person with less muscle mass? It means that you're really not clearing creatinine as well as you say you are. That the assumptions that your doctor is making, the assumption that the lab test is making, is that you are walking around with the muscle mass of a 32-year-old who jogs around Kapiolani Park in one of those cute little spandex outfits with the cute little ass cheeks that look like two little halves of cantaloupes. Well, I don't know about you, but we don't do that anymore for the most part. And my ass doesn't look like two cantaloupes anymore, unless the cantaloupes are starting to sort of rot, like most of the vegetables in my vegetable drawer that have sort of turned into a brown soup. So the assumption that I am making as much creatinine and breaking down as much creatinine is false. So when they look at my normal creatinine level in a lab, we're making a wrong assumption. So I am not going to clear drugs as well as I did 30 years ago. Okay. So, I have just a few minutes left. We talked mostly about what your body does when you put chemicals in it and why you need to be wary of putting too many chemicals into this closed system. I also want to leave you with the idea of which chemicals you put in is also very important. Your body has little chemical messengers that tell your muscles to move, your gut to move, your eyes to focus, your brain to be alert. One of the primary chemical messengers that you have in your body is called acetylcholine. And every chemical messenger that you have generally goes all over your body. Acetylcholine happens to be one of the most important. It's so important that in Alzheimer's disease, the major drugs that we've designed to combat Alzheimer's disease are designed to increase levels of acetylcholine in your body. And many drugs that we take, unfortunately, are designed to block acetylcholine. That's why they are called anti-cholinergic. What happens when we block an important chemical messenger in the body like acetylcholine? Well, we can have changes in mental status. Our attention will be impaired. Our cognition will decline. We can have memory loss. We can become dizzy because acetylcholine is designed to keep you alert. It's designed to focus your eyes, give you saliva, help your gut do peristalsis so that you can make a doo-doo, right? Help your bladder to squeeze so that shishi can come out. It can keep your blood pressure normally regulated. Now, sometimes drugs are designed to block acetylcholine for specific reasons. For example, sometimes drug manufacturers feel like, we know that a lot of times we get older, women, they feel like they can't make it to the toilet on time because their bladder is like having little spasms. So they say, hey, we know a neurotransmitter that squeezes the bladder. If we block that neurotransmitter, you won't have to run to the bathroom so quickly because your bladder won't squeeze because we're going to block acetylcholine. And you say, ooh, I'll pay $150 for that. I don't want to have to run to the bathroom. I want to block acetylcholine. Yeah, I want to do that. Will Medicare pay for it? Because I'd like that. Unfortunately, remember I said, you're a closed chemical system. And if you try to block a neurotransmitter for one part of your body, it doesn't know that that's exactly where you want it to go. You don't get to take that pill and go right there, right? It's going to get absorbed into your bloodstream. It's going to go everywhere. And when you block acetylcholine at your bladder, you are also going to, for the most part, block acetylcholine at your brain, at your skin, at your eyeballs, at your gut. I know. But also at your bladder, which is kind of what we were looking for. So I'm going to give you another tool called the anticholinergic burden score chart. And you can take a look at your list of medications and see if it's on that anticholinergic burden scale chart. And if it is, you'll just ask yourself the question, am I getting a little sedated? Am I constipated? Am I having trouble emptying my bladder? And before you let your husband or your friends go to CVS pharmacy and buy something over the counter, you're going to make sure that they take it to the pharmacist and say, are these medications anticholinergic? Because the answer is going to be yes. Because anything that you buy over the counter at anywhere, at Times Supermarket or whatever, that's designed to stop your nose from running, to help you go to sleep at night, to treat your cold symptoms, are going to be anticholinergic, right? That's why when you take those cold remedies, your mouth is dry and you sleep. But then also you might notice that your husband gets a big full mass in the lower part of his belly, and and it takes him like 20 minutes just to pee. Which is kind of funny if he can eventually pee, but it's not funny if he then doesn't pee at all that day and ends up in the ER. So remember that you're a closed system. So here's the second tool that I'll give you that you guys can play with. Here's a copy of it. Basically, it says, like, here's drugs that they gave a score of 1. They kind of made a system where they said, well, if things are mildly anticholinergic, we'll put them here. If they're just sort of medium anticholinergic, we'll put it here. But if they're really going to make you stop peeing, I'm going to put it over here. And you're going to recognize some of these drugs. So here's an old-time antidepressant, amitriptyline. Here's, let's see, here's all of your over-the-counter allergy, cold, and not all of them, it's the older ones, you know, the newer ones, but you'll see these diphenhydramine, that's everything you can take for like seasickness, and it makes you sleepy. Diphenhydramine, that's Benadryl, so that's your Tylenol PM. The PM part, oh yeah, Hazel's looking at me. Sorry, honey. Yep, you're busted. Okay, this is the thing you take when you get dizzy and the doctor, you say, well, I'm kind of dizzy, and the doctor says, okay, I'll give you meclizine. So you're going to see a lot of familiar, all the usual suspects in here. And so I want you to go through and see, so here's some of the ones that they use for like, here's what they use for everyone who says, oh, sometimes I leak, right? Ditropan. So I want you to be really careful with those drugs.
Well, we better thank Shari for her informative talk.
Sorry. That's right.